Okay, beautiful. All right. So this case, as you can see here, the slides, please. The patient is a 66-year-old, had a multi-vessel disease. We have done other vessels, LED, now has brought back for the RCA PCI, normal ejection fraction. I think that's what we need to do, very calcific RCA. Let's go to the angiogram. Okay, so this basically, we always, as I said, we always take a picture of the previous vessel, which we did. In this particular case, Circ has a moderate disease, about 60%, had a LED diagonal. You see that nice, very good. And now patient is here for this RCA. Look at the very angulated mid RCA. It looks like a very calcific nodule, then very tortuous distal and distal disease, and then there is a bifurcation. PDA, although you can say RPL, you can ignore it. If need to be, we'll send some flowers. But it's a small vessel there. But clearly, distal RCA lesion and there is a PDA lesion. Mm-hmm. And then, since we have done 3 cases of the rotational atherectomy, the orbital atherectomy team called us, summoned us that how can we not do OA? So we said this case is a good case for OA. But before that, we showed the IVUS. How do you like that? IVUS before the atherectomy.
No way.
Kiski.
Sure.
All
right.
Yeah.
Okay, I start.
But only thing is, did not do OCT. Next case will be OCT, Roxana, guaranteed.
Okay, Dr. Sharma.
Yeah.
So this is
Okay.
like
I was on the main screen. Yeah, good.
yeah, mid RCA has an eccentric carcinoma lesion, and the proximal has a definitely 360 carcinoma, and the diffuse looks like not protruding too much, but definitely severe carcinoma 360, and some part is eccentric, and the other half is normal. So this is the population. So
what size is the vessel?
So distal reference is a 4.3 vessel.
Wow.
Yeah.
Mega vessel.
Yeah. Lesion length is 38.
Okay. So, okay, we can go to angiogram again, please, now. So just to say, we thought it will be a calcific nodule. Remember, if you stop it, it looks like that maybe the nodule, but there's no nodule.
Yeah, not that much.
Yeah, but that's okay. So it's a very calcified 360. Look at this. Tram track.
Yeah, we could see it. We
Calcium,
see it.
but no nodule, which is okay. So this we are ready with the orbital atherectomy with a 1.25, and we have Viper flex wire, and we are going in.
All right, so as you're going in, I'm going to ask this panel here, after Eclipse, where are you using orbital atherectomy, if at all?
Beautiful.
Sunil?
Yeah,
What's
I
the
mean,
panel?
Down the line.
we occasionally still use it in specific lesions. So, for example, really, really large vessels where the high speed can be helpful. But our use is really, I think, decreased quite a bit, particularly after Eclipse.
Good.
Davide?
Only when other options are not available, including the non-compliant balloon. If it's not an option, then I would go in a calcified nodule like that with the orbital, but otherwise it's very limited use now.
Deepak?
Likewise, I initially when the device came out was somewhat enthusiastic because it was just easy to set up and control everything right on the table, but at this point, I think if I'm going to do atherectomy, typically we just go with roto.
John?
Yeah, I would say nationally it's at least 2-to-1 in favor of rota. So the ones that I use orbital on, as has been suggested, that the less severe the narrowing of calcium, so that I don't need a front cutter. I'm likely to still be able to cross, and I still want to get some debulking.
There definitely are cases where we
when I would
see
use
this very beneficial.
In very tortuous areas like this, you might have some better purchase there getting that down there. So this would be a good one for orbital.
And we see you.
what's
Dr.
problematic
Sharma,
here
you want
is-
to talk through how you use orbital atherectomy?
Yeah.
Like
So
you give the
basically,
forces?
remember orbital 1 millimeter per second, and you can go compared to rota where there is a packing motion. This you can go forward, but make sure and back and forth that because machine will stop at 25 seconds. So back and forth, you need to go forward and come back 1 millimeter per second. And even if you crossed it compared to rota, when you are done, you one polish. You don't need anything more here. Every time you'll do, and particularly if you will give you a better lumen, and we do 80,000 RPM. In our lab, probably we used to do like 10% of the 65 cases, rotablation, atherectomy in the past. Now actually about 10-15%. Now it's only maybe 1 or 2 cases per month, which I have to do it for the fellows because they may
Watch
go into
that
the
distal
practice
wire
and there they
again
have
with
OA
your
only.
fellow.
Yeah. Yeah.
I mean,
So
one of the
you-
biggest.
You've reduced your cases, go ahead.
I was just going to say, one of the biggest benefits of the availability of orbital atherectomy is that it forced the evolution of rotational atherectomy.
Yeah.
So it made RotaPro, which was, I think, a good
Yeah,
outcome.
RotaPro, yep. Okay.
And
So-
not only that, the next is that we are getting the burr. I just went to their plant, the complete burr, that means on both surface, distal and proximal. So that we tested, the problem came out, 1.25 burr still gets stuck. So we need to work a little more on, but whole issue about the burr entrapment, which a lot of people are worried with the rotational atherectomy, hopefully will not happen with the new design, but that's a little far away. Until now, we do the same. And here, this is the typical of orbital. This is what we originally published when came out with the 20 cases. It caused a deep cut.
Dr. Sharma, look
which it
at
has
that
done.
distal
Yeah.
right there, not
That's-
very
yeah, so that's
distal
all
into the
pseudo-lesion.
PDA.
All that is the pseudo lesion. Yeah, that's a
Yeah,
pseudo lesion.
that's what I want to make
Yeah.
sure that we,
Yeah.
because we didn't
Yeah.
see it before. That's the wire. So
Wire,
maybe
yeah.
you,
Yeah, that's
because
okay.
that's a
Because we never
really
touched it.
important,
So not a
important
concern about
teaching
there.
point.
It's a
We never
crinkle
went
effect.
that far. It's all the pseudo lesion
It
of the wire.
wasn't there
even
before,
despite
we all
using
of
the
a
wire
sudden
for
see it. You see it, everybody? Good.
Okay, like, you want to emphasize this again here?
Yeah,
Right there.
yeah, see, you, all of a sudden you see, it looks like someone took bites out of the.
No, not all of a sudden. Remember, we never took the picture with the wire.
Yeah,
See, picture was without
Yeah,
the wire.
that's because
and
of the
you see
redundant
that
loop.
bend.
To happen.
It's the
So-
redundant loop that is now in a kringle formation.
Exactly, it's the wire
Yeah.
straightening
the
out the
PL
vessel
system.
and showing the pseudo lesions.
PL
Okay,
system's missing, though. I
let's
think,
keep
right?
going. Now you're going to change the wire to a workhorse.
Yeah.
And
Yeah,
everything
Yep,
will
this is
go
the run
back to
through
the,
then.
now,
And
now,
what,
a little
I'm going
nitro
to dilate
or-
with a 3.530
3.530.
balloon, and the stent will be what?
3.530.
One of the other advantages of Orbital is that the
438?
wire is a little
Yes.
bit easier to work with.
What?
And I think that people are just
Okay.
picking up atherectomy early on. They actually favor Orbital because it's easier to use. A Viperflex
Okay.
wire is easy to steer, and it's easy to get it up there and into it. And because of the differences in mechanisms here, you want to take as much advantage of the centrifugal effect
Go.
and stay on the lesion for a prolonged period of time.
Yeah.
Unlike Rota, where you're sort of pecking.
Bruno, what are your thoughts here on this case so far? You
Yeah,
used
the stent
orbital atherectomy?
Open it.
So we do not have it in the shelf in our lab.
Yeah.
And we thought about taking it in the lab, but we decided to stay with IVL, Rota, and specialty balloons.
That's right, so no orbital. Arthur?
Same. I bet we haven't used it in 6 months.
But I mean, nationwide,
All-
atherectomy's been decreasing anyway with the advent of IVL.
With IVL, yeah.
Yeah.
But increasing
So-
in terms of the combination.
Yes.
Yeah. More on the combination
rototrypsy,
therapy.
Yep.
Yeah.
You want to
Okay,
get
here
that?
comes the stent. Pretty long
Yeah, this
stent,
is the
Dr.
stent now.
Sharma.
Yeah, we thought that we'll use a long stent, but it may not, it
So
will not
long.
make the turn despite do a good balloon dilatation. Get a fielder wire. Let's see. So question comes down, what you want to do? You want to
This looks
take
like you
out,
need a
put a
guide
guide liner?
extender.
Guide
Yeah,
extension.
Guideliner,
This
maybe,
was made for a guide extender.
guide extender.
fielder wire.
It's a
Your
very
choice.
funny right coronary, it comes up
Yeah.
and down and,
I think from an operating standpoint, we're so glad we have all these atherectomy options, IVLs, great hemodynamic support. But from a practical standpoint, the thing that's made the greatest benefit is a guide extender.
yep.
Yeah, no question about it. If you ask that what has been the discovery of the century in last 10 years, not any of those stents or atherectomies. Atherectomy already had been done, but I would say the guide extender that made our life so easy. Although since we had the fielder wire before, I just want to see if we can work out with a double wire. If not, then we go with our guide liner. Yeah, looks like it's not
will.
going to work.
Yeah, you're going to need it.
It's a really long stent. So while you're doing that and getting us the guide liner, Dr. Sharma, we're gonna, if
Yeah.
you don't mind, we're gonna go to Dr. Kinney to see how
Yes,
far
very
she's
good.
done.
Yeah.
And-
We are back here.
Yeah.
Now we are ready to put our guide liner or Godzilla, what we have.
Guideline.
It's a guide liner, Godzilla. Okay. So same, we have to advance it on the balloon. So we are taking our same balloon first, although it may be a little too big now.
Get a new
right?
3.5 balloon. Yeah.
Yeah, can get a, because that was a long balloon earlier.
12
Yeah,
is it?
yeah. We can get a 3.5 12 balloon, and so that we,
Yeah, one other thing that could have helped, it's a little late now, would have been a support guide, like an
A different
Amplats-type
guide,
curve
yeah, I
guide.
was just thinking.
yeah, no, we started this case with the Amplats guide, and that didn't sit well. So we thought that it will be the, you see this now, first the picture was done with the Amplats guide. This is the Amplats guide. So
Yes.
that was not sitting well. So we tried to manipulate, and it did not, and then brought the Akari guide, 1.5 went very nicely, very set. And the only thing is with the, as Roxana mentioned, this is very, we call a crooked band of the RCA, proximally as well as distally. So we are still dealing with the proximal, but remember it was a long balloon, which we have used 3.530. So came out, the guide is still moving, that's okay. We'll do it again. Practicing wiring few times. We already have paid a lot of big price, although we are able to do that case. When these wires do come out, when anytime you try to move, these tortuous, there's a little leeway and they just come out. Look at the tortuosity, see? Little tortuosity and this comes out. But we were right now, earlier, the first wire was the fielder and this is the run-through wire, but this is, okay, so what I'm going to do now, stop at this level. So once it goes to this tortuous segment is the trouble. Yeah,
Now
so
you
we
bring your
bring our
guide liner with
Godzilla.
a smaller balloon.
And here we are going to do balloon, yes.
With a
So,
shorter
and
balloon.
Not only balloon, a small balloon and the new balloon.
Yeah.
Not the used one. The earlier we
Exactly.
had the used one. So same that you have to. Now we advance the wire. Not pushing, still going to push the guide. Oh,
Oops.
wow.
Okay,
So
wow.
pushing the guide. So looks, what happened is the probably guide became soft. We still have our AL 0.75.
Yes.
Deepak said maybe that's what will fit a little better now compared to what it did earlier.
That's a great point. I mean, equipment fatigue is a real issue.
Yeah.
When you're pushing this hard on things, you could lose your backup and support.
Okay, so I'm going to go with the balloon first only.
Yeah, that's what I was just gonna
Let's go with
say.
the
Why
balloon.
don't you
Yeah.
bring the balloon
Yeah.
first, then
Yep,
the guide
that's what we are
liner?
doing, yep, yeah.
Let the balloon go a little bit further. Okay, now
No.
work with the guide again.
Yeah, go up here, yeah. So once you do balloon, then adjust your guide. Now, get a better guide position, which we are doing now. Then advance the wire. No, still the same. Anytime we try to go with that curve, I think maybe we
I
go
think
back
you need
with
a
our
new
field
guide,
wire.
Dr. Sharma.
Yeah. So last try, if we still have it, then we have our old AL 0.75, which was the original guide. That's what we decided originally, actually, when we had discussed the case, that we are going to use that.
Maybe
Okay,
a
one more
second
try.
wire there too, maybe.
Yeah. Yeah, so maybe second wire, which we did originally 2 wires.
Yeah.
Did not work out.
Just to deliver
Go
the
here.
guide liner.
Go here. Yeah.
SS, what about a anchoring balloon? Was there a small conus branch or something that we could anchor everything in?
I
But
didn't
then
see one.
the Godzilla has to come out. So
didn't
there will
have
be
any.
2 balloons from Godzilla will be impossible. Yeah, let's see now. Delay, deflate. You see that? Now we are moving a little bit,
Yeah, you gotta
little
inch-
bit, little bit.
Inchworm your way down there.
Yes. Yeah. No, but I think it will not go yet till we get little purchase on the wire.
I think I would push the guide in first before you push the wire, SS.
Okay, go up here. Okay. Oh,
Guide is out.
came out same. Yeah, I think it's basically will require the new guide, AL 0.75. I think that's probably will be the best one now, in my opinion. Okay, deflate now.
Okay. Looks
Okay,
like
now
you
it's a
got-
nicely coaxial. Go up now. But every time we go a little further, it just pushes it
Pushes
back.
it out, yeah.
See that? Yeah, deflate again.
Okay.
Same, you have to deflate and slowly advance.
Decent shape there.
Okay,
Now,
let's see
can you
now.
push the
If I
guide a
can get
little bit more,
balloon.
SS? While you
No,
got the
guide will come
guide,
out.
make the
Balloon.
guide better now with the Godzilla in.
Yeah,
Because the guide
now
is
go,
still
go
pushing
balloon.
out.
Yeah,
Look for a trio compliant balloon.
yeah, otherwise you get a,
Give me
yeah,
trio compliant
Yeah.
balloon.
yeah.
Trio 12.
Lectures.
There you go.
Okay, now deflate. No, lectures and then case number 5.
Okay, we got to go to the cases, SS.
Yeah,
You
no,
said.
but here, just 1 second, go to the step by step. So just like, you will
Okay.
go up again, that we are struggling, that means it's same
We're
thing again.
learning.
Yeah. All right, I think we reasonable case that we try to show everything possible, except that now the guide we need to change than anything else, because anything we tried did not work out. Yeah.
Yeah.
Okay.
I would
Okay.
start with everything brand new, besides the
Start
guide.
brand
new.
new,
That's it.
please
Get a
put
new
it on the
balloon, get a new
side,
wire.
but we need to go to our guidelines and come
Yeah.
right back to you,
Yes.
okay? We
Then
will
come back.
come back to
Beautiful.
both of you.
All right.
And excellent, wonderful. Thank you, Dr. Sharma.
Okay. All right, guys, that's where we left you. That we were doing the orbital atherectomy for that 360-degree calcium in a large vessel. And then after that, this is the result, which saw a little dissection line, which is common. Then post-dilated with a 3.5, 30 high pressure, came out perfect. And then whole issue was advancing the guide liner. And therefore, it required little time. And we went back and then able to put the guide liner there, post-dilated. And you can see a fantastic result. Now we needed to take care of the distal RCA, which was there, open the AV continuation and then put a balloon and stent into the PDA. And this is where we came up. So with that note, I'm done, and Dr. Keeney is ready in room 2.